To today's lunch hour lecture. You're all very welcome, academics, visitors, speaker. My name is Professor Gilroy. I'm Professor of Immunology, Head of the Center of Clinical Pharmacology and the Department of Therapeutics here at UCL. And it really is my real personal pleasure to chair Nikki's presentation today. I'm asked to remind you, all mobile phones, please turn them off, chuck them out, put them away. Event code to access at the end of this presentation is 3282. I've been asked to remind you. And Nikki is a consultant neonatologist. She's got an interest and is a world expert in neuroprotection in the brain. She studied medicine in Edinburgh and came to UCL via Monash in Australia and Imperial College. She's an envious publication record of up to 200 papers and millions of pounds of research money. Such is an indication of her greatness, and we're very pleased to welcome Nikki today to give her presentation on the impact of cooling babies in protecting against brain injury. Nikki?
Well, welcome, and thank you very much for the opportunity to present some of the last 15 years of research this afternoon. It's a great honor to be here and to be talking about babies. And without further ado, I'm going to get into the nitty-gritty of what factors cause brain injury in the baby at term. I'm not talking about preterm babies. I'm talking about mothers who've gone to full term, 40 weeks, and then there's a catastrophic event right at the very end. The sort of factors that can lead to this problem is if the mum is in a road traffic accident and has hypotension, the blood supply to the baby gets compromised. Or the cord can slip down and there can be cord prolapse. The placenta can come away from the uterus, or indeed the uterus can rupture. All these things can lead to a lack of oxygen to the baby. So 85% of babies breathe alone. However, around 2% of them will need intubation and will need neonatologists there at birth. And around 0.1% will need chest compressions and adrenaline. So it's a very small number of babies that we need to look at. But on a world scale, you can see that 1 million babies die worldwide from birth asphyxia. And in the UK, 1,200 babies are affected. So you're going to hear many different terms: birth asphyxia, neonatal encephalopathy, hypoxic-ischaemic encephalopathy. I can't see down.
That's okay. I'm licensed to do this.
Thank you. So before we go on, I need to tell you the precise definition of what asphyxia or encephalopathy is. You're presented with a baby that you are there resuscitating. This baby is not behaving normally. The baby isn't breathing. You need to help the baby breathe. The baby has an abnormal level of consciousness. He isn't looking around and screaming. He's flat. He's floppy. He's comatose sometimes. And they're just needing help in the first few hours and minutes after birth. Very quickly, the babies are brought round to the intensive care unit, and you can see the sort of level of care that these babies have to have. Lots and lots of infusion pumps, an EEG, a ventilator, and lots of nurses looking after them. So how do we grade a subnormal level of consciousness in a newborn? They can't communicate with you. This was developed by someone called Sarnat in the late 50s, and you can see very simply how we grade babies from a grade 1 to a grade 2 to a grade 3. And this is based on how alert or how lethargic or how comatose they are, on what their tone is like, whether they have seizures, whether their pupils are fixed or dilated, whether they're breathing. That was in the 50s, but today we're a little bit more refined, and we look at the electrical activity of the brain. And you can see up here on the top left-hand corner This is a normal baby with electrical activity throughout the whole brain. In the bottom right-hand corner, you can see a baby 8 hours after birth with a completely flat isoelectric EEG. We know this baby's at high risk of abnormal outcome, of brain injury, and we know this in the first few minutes and hours after birth. So, briefly, there are two main patterns of injury. As I told you in the first slide, you can either have acute, profound, unexpected injury, catastrophic, lasting about 10 to 25 minutes, ruptured uterus, cord prolapse. Or you can have a chronic partial injury that occurs over 5 hours or more. And this is intermittent cord occlusion, for example. The sort of injury you get if you have the first type, the acute, profound, is this deep grey matter injury. It's these very, very active areas in the center of the brain that are affected. And this leads to cerebral palsy. If you have the chronic type, it's the area, the white matter injury, white matter around the brain that is injured. And this can lead to cognitive impairment and poor brain growth. So when I was training as a young neonatologist, we used to look after these babies and we just had a feeling of impending doom. There was nothing we could do for them. It was also a black box because we couldn't image them. We didn't know what was going on, what the pattern of injury was. And I must say in the last 20 years there's been amazing advancement. A 20-year program of research leading to probably one of the most significant advances in the care of the newborn is that now we know cooling the baby by 3 degrees for 3 days as soon as possible, and has to be within 6 hours, leads to significant improvement in their outcomes. And in 2010, the National Institute of Clinical Excellence adopted cooling as a routine treatment of babies with moderate to severe encephalopathy. Do you remember I showed you the chart with grade 1, grade 2, grade 3? This is for grade 2 and grade 3. We would offer cooling. You can see here this baby looks very settled, is sedated, has a cooling mattress wrapped around the body. We have a thermometer, internal thermometer in the rectum measuring core temperature, and we have a servo-controlled device that will lead to the baby's body temperature being around the mid 33.5 degrees for 72 hours. So, the benefits of cooling have been huge for the individual, the family, society, and UK economy. The number of babies that we need to treat for an additional beneficial outcome is 7. We know that some of the biggest claims for the NHS Litigation Authority come from obstetric claims, and this is around 500 million per year. These have been reduced significantly since cooling has come on. And based on a lifetime cost for each child with cerebral palsy estimated at £750,000, the economic benefit per additional healthy life of £800,000, and reducing the incidence of CP for around 10% has saved the UK economy at least 30 million per year. I'm going to take you back a little in time, just so you can see how we've got to where we are today. Cooling isn't really that new. Cooling actually is a therapy that was started 5,000 years ago in ancient history. And we see in some of the papers, the papyrus from ancient Egyptian, cooling was recommended for certain problems and diseases. Hippocrates advised snow and ice packing to reduce hemorrhage in the wounded. And it was seen in the Napoleonic Wars that the less senior injured soldiers after a battle who were away from the warmth of the fires survived better than the top-ranked soldiers close to the fire. And then there was all this interest in the last few decades about people who have fallen through the ice and have been rescued, but after 30 minutes to an hour, and have had intact survival. So we come back up to the 1950s, where actually in Russia and Scandinavia, there were small uncontrolled trials in which infants who were not breathing spontaneously at 5 minutes, the small percentage I told you at the beginning, they were dunked into ice-cold water of 8 degrees centigrade and then allowed to spontaneously rewarm. Now that seems quite a cruel thing to do, but actually in these non-controlled trials, the neonatal outcomes were better than the historical controls in over 200 asphyxiated infants. However, this research into cooling stopped quite abruptly in 1958 because there was a randomized trial done showing that in preterm infants, they had a greater mortality and higher oxygen requirements if they were hypothermic. And hypothermia became a bad word in the neonatal unit. However, then in the 1980s, a connection of several remarkable people at a remarkable time and in a remarkable place, UCL, led to some really, really important discoveries. These remarkable people were Osmond Reynolds, David Edwards, John Wyatt, and they were using a magnetic resonance spectrometer to look at the brain energy levels within the brain of babies who had birth asphyxia. The other realization around the same time was that actually when you have an injury, the cell death doesn't occur all at that time of the injury. Actually, cell death occurs over many hours, days, and even months after the injury. And so these two things added together to a realization that brain protection after the injury, i.e. after birth, might be possible. So let me just show you some of the very important data that came from UCL in the 80s. Taking a live baby down to the magnet in the basement, we were able to look at the brain energy metabolism, these squiggles, whilst the baby was being given intensive care. And you can see on this side, we're able to look in a live baby at the ATP peaks, the currency of cell processes. And on the right-hand side, we're able to look at lactate, which gives us complementary information, and this protein called N-acetyl aspartate, which gives you an idea of the neurons in the brain. These remarkable people, Dennis Azzopardi being one of them, took one single baby who had birth asphyxia down to the magnet on 4 occasions, 8 hours, 31 hours, 36 hours, and 55 hours. We would not be allowed to do that today. But what this serial study showed was that actually at around 8 hours, the baby had a very normal ATP amount. But as the time went on, the ATP declined, the waste product of ATP came up, the inorganic phosphate, and the phosphocreatine declined. So that by 55 hours, we're left with a very low ATP and a very high waste product, inorganic phosphate. And this was confirmed by 3 other groups around the world and has been termed secondary energy failure. And we believe that during the secondary wave of energy failure that we were able to see with the MRS, there is a cascade of brain cell injury and cell death. And this slide summarizes 10 to 20 years of work using what we know from these spectroscopy studies. If we look at the ATP here, we then have an insult or birth asphyxia. We then resuscitate, and the brain energy levels return to normal. You then have a latent phase that is called the therapeutic window, and if you don't intervene with anything in this time, you will have a secondary wave of energy failure that is corresponding to cell death, and you lose your ATP in the red. If, however, you introduce cooling in this stage here, in the latent phase, before the brain is committed to secondary energy failure, you change the trajectory of the energetics such that you preserve ATP and you prevent cell death or some of the cell death anyway. The reverse happens when you look at lactate to N-acetyl-aspartate ratios, and you can see here that if you cool, you will reduce the lactate, which is a very strong marker of cell death. So over the last 50 years or so, we have used preclinical models and then clinical trials in babies to come to the position that we had in 2010 from the NICE guidance. And for those of you who like epidemiology and statistics, this is a forest plot of all the clinical trials of cooling compared to no cooling in babies with birth asphyxia. And you can see in every single trial across the world, and that is the developed world, there is a reduction in death and disability. So what do we do with cooling? We bring the temperature down as quickly as possible once we have made that diagnosis with the EEG and clinical diagnosis. We bring it down to a rectal temperature, core temperature of 33.5 degrees and keep it there for 72 hours. It's very important we keep the baby settled and stable. We, in a way, put baby into a sort of hibernation state whereby the metabolic rate has come down, we don't feed the baby, we restrict the fluids, and we just sit there and wait. We observe the brain electrical activity and wait until 72 hours has passed, and then very, very gradually will we rewarm. So many people have asked, well, okay, cooling to 33.5 degrees, that's excellent. And there was no real study that gave us that magic number of 33.5 degrees. It came to this because it was probably the best temperature. So people then asked, well, what about cooling for longer and deeper? And a cooling trial was done in the States at great expense, cooling down to 32 degrees for 96 hours. And actually, that was dangerous. That was deleterious to babies. And we have come, luckily, to probably the most optimized protocol of cooling, and that is 33.5 degrees for 72 hours. So how does cooling work? This is cooling after the insult. I think based on the knowledge that cell death is occurring in the hours, days, and weeks after the injury, we know that cooling will reduce cell death and actually give the brain time for endogenous repair. It reduces metabolism so that there's a lower metabolic rate and less use of ATP. Cooling reduces inflammation and the inflammatory cascades, reduces seizures, and will reduce all the cascade of injury such as glutamate, reactive oxygen species, and mitochondria. Who do we cool? You'll probably notice that all those trials were done in the blue, dark blue areas. They were done in high-income country settings. But ironically, the highest incidence of asphyxia are in the low and mid-income country settings. Research over the last 5 years has shown actually the low-tech methods of cooling, shown here as a water bottle or ice packs or indeed ice cubes put into a rubber glove. If there is sufficient nursing staff and control that the temperature does not go down below 33.5 degrees, these are safe and effective as well. And I wanted to share briefly with you some work I did 10 years ago in Uganda. Now this is a low-income country setting, and I did some cooling using water bottles. It's not really to tell you about the result of the trial, but show you a really fascinating physiological response of the body. This graph here shows you two things. Number one, in the blue, with time along the x-axis and rectal temperature along the y, you can see in those babies who were randomized to water bottles, we kept their temperature down for around 72 hours. But in those babies who, though 10 years ago it was ethical to randomize, those babies who were randomized to normal care took a long time for their temperature to reach normal. Now these are asphyxiated babies who have abnormal consciousness at birth, who have abnormal respiration, and have seizures. And you can see that it's taking 16 hours or so for their body temperature to reach normal. Looking back, as so often one does, at work done in the 1950s, exactly the same was seen in babies who had had birth asphyxia and were studied. Just after birth, those who had asphyxia remained cold intrinsically for the first 16 hours and then gradually came up to a normal temperature. This suggests to me and to many that actually the body's own response to asphyxia is to shut down metabolism, bring the body temperature down to around 33, 34 degrees and preserve energy and hopefully improve outcomes. Of course, when we take a baby to the neonatal intensive care unit, we want to bring the temperature up immediately to normal temperatures. So actually, this just does tell us that the body is doing something in these settings. It is another issue when we come to doing trials in these low resource settings, because we need to build in the fact that there is an intrinsic endogenous cooling in the control arm. So in the last few minutes, I just want to say a bit about the future. We are so impressed with cooling. It is safe, it is effective, but it isn't the silver bullet. And although we know that cooling is effective, it takes you to treat 7 babies before you affect 1. The issue is that actually, what about the other 6? And so in the last 10 years, we've been looking at things that you can add to cooling to see if you can augment the cooling effect. So why should you be looking at all of these different agents that I've shown you here? The noble gases, xenon and argon, melatonin and erythropoietin, allopurinol. Why not just look at one? Well, we feel that neuroprotection is likely to be tailored to infants depending on how severe the insult is, their inflammatory status, their gender even. And different agents complement each other and will probably need to be tailored at different times for different babies. UCL has had a long history with noble gases. In fact, xenon was discovered here by Lord Rayleigh. And we've done some work with xenon augmenting cooling. We've also done some work with argon augmenting cooling. Now these gases are, as you know, noble gases. They react with very little, but they have a specific shape and are able to lead to neuroprotection in certain circumstances. And we've published on this, and it is something that we are trying to take into clinical trials. The other hormone that is very, very protective is melatonin. And melatonin is probably one of the oldest signaling molecules known in all taxa. It is, in our bodies, stimulated by darkness and inhibited by light. And usually we have our peak of melatonin at around 4 in the morning. What I'm talking about is not our physiological levels of melatonin, but levels that are 10 to the 5 times that. These are hugely protective in the brain. And I've spent around 10 years looking at this. We've published, and we're working with a pharmaceutical company to try and bring melatonin into the clinic as a neuroprotective agent. Melatonin is acting, for those of you who are scientists, is acting on the mitochondria. It's mopping up all the free radicals, it's preventing cell death, and it's preserving ATP. Erythropoietin is another very attractive drug. Clinical trials going on in the States at the moment using cooling plus EPO, and these are very promising at the moment. EPO is something that is leading to cell survival. It's neurotrophic, it's anti-inflammatory, it stops cell death, and it's antioxidant, and it acts early and late. And we're thinking about using EPO for many weeks and months after birth. So future neuroprotection is likely to be a combination of cocktails, and ice. Cooling is here to stay, and this is where I think we may be going. After a baby's born, we cool them as quickly as possible. We need to give them something like melatonin or allopurinol to mop up the free radicals, perhaps a noble gas. And then the thought is that once cooling is over and the first wave of injury is over, that we start to add something that is leading to brain protection and regeneration, and that is EPO. So that's what we're working on. We hope by this time next year we have something that we can use in clinical trials to augment cooling. I've had great support from many funders, particularly the MRC, Wellbeing of Women, Action Medical Research, the Royal Society, and Chiesi. And I've had many collaborators across the world. But most of my thanks is to my team who work in Queen Square and who work in the neonatal intensive care unit here at UCH, who have been looking at brain research, I think, over the last 30, 40 years, and hopefully will continue to do so. So thank you very much.
That was a heartening and tremendously impressive research showing how observations from the clinic come back to the lab and then head back to the clinic again. It's tremendous. A real credit. Thank you. Questions for Nikki?
So this is a question on behalf of Slido. How long do you think it will take for this cooling treatment to be rolled out across the board, across the UK, and how many sort of babies can you save, essentially, with this therapy?
So cooling therapy is rolled out across the UK. That's done. It's rolled out across developed countries, and we are significantly reducing the number of babies with disability. That's really clear. I think what isn't so clear is where the major bulk of encephalopathy occurs in the mid and low resource settings. And in some areas, cooling is being done. In parts of India, cooling is being done. I've just come back from Ghana, where they are doing some cooling there. But I think one of the questions I want to address in these settings is actually, is the cooling that we do in high resource settings better than the endogenous cooling that babies actually do themselves? And I think that is, to me, one of the biggest questions. 16 hours of cooling and gradually rewarming may actually be as effective and safer in a setting where you don't have the nurses and you don't have the intensive care and the blood pressure support and the glucose support. So that's one of my big topics that I'm going to focus on in Accra. I've got some great collaborators there.
Lily?
Nikki, thank you very much. It was really interesting. I thought it was amazing that just dropping the temperature a tiny bit and adding on a bit more time turned into something that was now negative rather than positive. And I can imagine that those trials were terminated very rapidly and so on. But does anybody know what happens that it then turns into something negative?
So, because of time, I didn't show you the work that I've done in the pig as well, and in other models going down in the temperature. I think when you reduce temperature below a certain threshold, you stop the blood perfusion, and so you start to get a substrate lack, and actually you get a secondary ischemia. What they saw in the babies who were cooled for 96 hours and who were cooled at 32 degrees is that more of them died, more of them needed ECMO, they went into respiratory distress, and it seems that the body has this threshold temperature below which systems start to break down, enzymes start to not work. So. Yeah, and that's what is so important in these low resource settings, that you don't let the temperature get down, and I think that's really key.
Emma has another question.
Yeah.
Yeah, go ahead. I'm sorry.
Another question. You mentioned that repeated magnetic resonance scanning of neonates, which you showed in an earlier study, would not be allowed today. Why is that?
So when babies are born with asphyxia, they're very unstable. Often they need, they do need ventilation support, they're sedated, and we try and keep them calm and in one place. We do sometimes take babies to the magnet if we're unsure of what's going on, but it's quite disruptive to move a baby into a transport incubator, take baby along the corridor and scan and maintain temperature, even one time. But if you do it 4 times, it's definitely you're not able to ensure that the temperature's kept at the right level.
Gentleman here.
I didn't get a clear idea of what you're doing with the noble gases. Are you letting the babies breathe these things?
Yes.
And what proportion?
So, with the noble gases, we have used in both our preclinical model and in babies, we have been giving 50% xenon over 24 hours, along with 72 hours of cooling. In our preclinical model, this has been effective and has led to improvements. But when we came to do a clinical trial in babies with xenon, it was a very difficult thing to get babies into the central hospitals for xenon administration early enough. And the mean age of getting xenon was around 10 hours, so we didn't see a benefit in the clinical trial. Argon is slightly different. We've been giving argon at 50%, connected to, from a cylinder connected to the ventilator, and instead of the nitrogen, you're giving argon. And we've seen remarkable improvement with argon. I think argon is more promising, it's much cheaper, it can be in every hospital, if necessary, around the UK, and it could be present in the ambulances. So we are looking at taking argon into a clinical trial, but the key point is that it needs to be given early, and that needs to be given within the first 2 hours.
More questions? Gentleman here.
Follow on to that one. Why does replacing nitrogen with a noble gas benefit?
Okay, I thought this might come up. So some of the mechanisms of action of argon versus xenon, they're remarkable, these gases. If you look at argon, argon is acting on the GABA agonist, but this is only at hyperbaric oxygens, hyperbaric conditions. It has oxygen-like properties, but where they're acting mainly is in the apoptotic pathway on the proteins BCL2, suppression of caspase 3 and cytochrome, and better expression of HIF1 alpha and ERK signaling. So they're acting down the intrinsic cell death cascades and augmenting the other properties of hypothermia, because hypothermia is also acting on many of these areas, but they seem to be complementary. You can see there's slightly different areas where xenon acts because of xenon's particular shape. Xenon fits into the NMDA signaling site, and it also acts on the TREC2-pore potassium channel. But you know, this is very, very attractive because you can attack the baby in many different areas: temperature, intravenous drugs, inhalational drugs. So there are many, and of course these are so lipophilic, they can get into the brain immediately. So very attractive.
More questions for Nikki? Gentlemen.
Let's say you have a baby where you're not sure about the severity of the brain injury. Maybe it's healthy, maybe not. Do you also cool these kind of babies down, or is there any risk associated with cooling down a healthy baby? Yeah,
so very good point. We go through a series of tick boxes, if you like. Is this baby fulfilling criteria for cooling? They have to have had a issue around the time of birth, need resuscitation, have had an APGAR score, so be needing help with breathing, for example, at around 5 minutes. And then they have the EEG test. So if they have a completely normal EEG with lots and lots of activity, were you here for those slides? if you've got very active EEG, you know that that baby's going to recover and the brain is going to be okay. But if you have a flat EEG, you know this baby's at high risk of brain injury. Of course, there are babies in between where it's just slightly abnormal. And that's something that we're in discussion at the moment. What about cooling the mild asphyxias? Is the benefit better than any of the deleterious effects? I think over time we've come to realize that actually the deleterious effects of cooling are very minimal if you keep the temperature stable and at 33.5 degrees. And the movement now is that actually we should be looking at cooling these mild babies because outcomes of milds show that their cognitive development is perhaps less good than their controls, and cooling might be able to improve that. So we're just at the moment talking amongst experts whether we should be doing a mild encephalopathy cooling trial.
I guess superficially, when you think about it, Nikki, you kind of convince yourself that you're just cooling everything down, you're just slowing down nature, biochemistry, immune response. But I suspect that the temperature of the brain doesn't go down.
It does.
It does?
It absolutely does.
Okay. How do you know that?
We know that from our preclinical models. Of course, this is extrapolation. We also know that from MRI techniques. You can do some quite fancy MRI techniques looking at temperature of the brain using MRI, the spectroscopy. And certainly from preclinical models, we know definitely that if you cool your core temperature, remember that blood is getting up into the brain and circulating around the brain, and it will cool down the central parts of the brain very quickly.
And in addition to that, I guess you're evoking a very ancient primordial response, a sequence of hormones that you wish to bottle and use pharmacologically in the future.
Yeah, yeah.
Marvellous. One or two last questions. I think we need to wrap it up soon, Emma. Wonderful. Thank you very much for coming today. Thank you very much, Nikki, for sharing your research.
Thank you.